So I'm going to talk today about thin endometrium during FET, frozen embryo transfer cycle, and how to manage. So, and that's one of, like, with more and more embryo freezing and freezing cycle, we start to face more a problem with thin endometrium. So we tried to figure what to do. This is a medical school where I work, and I've been here for the last 17 years. So endometrial sickness is directly correlated to increasing circulating estrogen, and in a way can predict the success of assisted reproduction. There is no consensus, like as Dr. Walid said earlier, there's a lot of protocols, a lot of different way, and there is no consensus what's the best way to prepare the endometrium. With our natural cycle, program cycle, a combination of both, so on and so forth. There is no clear definition what thin endometrium is. And you read literature, some would say 7 millimeter, some would say 8 millimeter. And I think if you read it more and more you read, I think for a fresh cycle, it's less than 8 millimeter, for a frozen cycle, around 7 millimeter. Although there is no consensus about what is a thin endometrium. And the incidence varies. Like if you look in IVF cycle, which is again the first cycle, it's 1 to 2.5%, depends what you read. And it's likely higher in FET. I mean, the biggest advantage, not the difference in a natural cycle, during the stimulation cycle, the estrogen usually is very high. So in a way, the endometrium exposed to higher level of estrogen compared to an FET, frozen embryo transfer cycle. As Dr. Walid also mentioned, there's a different way. Like if they definitely 10% of the patient, there's always a variation in endometrial sickness. And there's a lot of different ways, like different reasons, fibroids, adenomyosis, polyp. The patient habitus, patient previous surgery, the position of the uterus, even the position of uterus between now and like an hour to an hour later, it depends on the bowel movement and so on and so forth. The ultrasound machine, the inter-observers. And again, we talk about 7 millimeter, 8 millimeter, 9 millimeter. We'll make it 1 millimeter difference from somebody you're going to call a thin endometrium to what we call adequate endometrium. So there's a lot of variation that we try to minimize it by standardizing where to measure, right? You have to have a sagittal view, and you try to measure 6 parts of the endometrium. It's like approximately 1 centimeter from the top of the uterus. So try to standardize it, so like at least when we talk about measurement, we know what we're looking for. Of course, to the left is the endometrium that we'd all love to see, and the right endometrium that we dread to see on the FETs, and we don't know what to do sometime on those patients. So of course, the history is a lot of the patients that we can look at. What would be the reason for that? What would be the reason for the patient to have a thin endometrium? And of course, history of surgery is going to always come on the top. Myomectomy, DNC, Asherman syndrome, of course, endometritis, although never been proven to cause that. Hyperandrogenemia. Okay, high level of androgen can also inhibit the growth of endometrium. Hydrosalpinx, we know that like this fluid into the fallopian tubes that can really have a high level of cytokines that can affect that. Patient radiation. Smoking is a big deal. Of course, septic abortion and postpartum curettage. I don't know whether that's still done or not, but like in the old day, we used to have the patient bleed and they go get like the big curette to try to clean the uterus, right? And definitely that in the Asherman. Tuberculosis endometrium, I don't think that's as much as used to be. And idiopathic, there's some patient where you don't know why this is happening. We cannot really explain the reason for it's happening. This is one of the very earliest studies that, I'm sorry. This is one of the earliest studies, this is one of the earliest studies that looked into the relationship between endometrial sickness and outcome of natural cycle, right? And this is by one of our Dr. Calla from England, and looked into what's in endometrium and what's the pregnancy rate on those endometrium. And you can see patients between 7 and 8 in endometrium lining have a lower implantation pregnancy rate between 9, 10, 11, and 12, and so on and so forth. And if you look at the difference between the two groups, so group A, that's the patient has endometrium sickness between 7 and 8, and group B is the patient endometrium sickness between 9 and 14. And there is no difference between the two groups till you go all the way down here. Implantation rate was significantly different, clinical pregnancy was different, ongoing pregnancy, and so on and so forth. So this is one of the earlier studies that is emphasized the importance of endometrial sickness and the implantation and pregnancy rate. The interesting part of that study, again, that when they looked at the endometrium, it was an endometrium below 7 millimeter or above 14 millimeter. Both of them has a low pregnancy rate. So it's not only the 7 millimeter endometrium or 8 millimeter was bad, the 15 or 16 millimeter endometrium was also not very receptive. So that's something we have to keep in mind when you look at endometrium for implantation. And the conclusion is said in medicated frozen embryo transfer cycle, an endometrial sickness 914 measured on the day of progesterone supplementation is associated with higher implantation pregnancy rate compared with endometrial sickness 7 to 8 millimeter. And I think that was one of the earlier studies that make us think very clearly on the sickness endometrium. Now, this is another looked in, it's a systematic review endometrial sickness, and that was after IVF. So this is not a frozen embryo transfer, but also give us an insight on what to expect on the endometrium. So it's a meta-analysis, like review 1100 came by like more like 22 article. And that's really important to look on this. And that's like always gonna be the paying attention to what type of study you're looking at. So on total, patient was lower endometrium below 7 millimeter versus above 7 millimeter. Patient below has a lower pregnancy rate. And you see the confidence interval 0.27 to 0.67. So it did not cross 1, which basically means statistically different. So total, take it everything together, patients with a thin endometrium below 7 millimeter has a lower pregnancy rate. That's it. However, if you go and you cut those patients in two groups, the prospective studies and retrospective trial. The prospective trial, which is not many of them, they see the confidence interval, it crossed the 1, which is basically mean it's not statistically significant. So this is start to say, well, maybe 7 millimeter we use as a cut, but it really is not, it's maybe not the most important single factor in determining which patient you're going to get pregnant or not. Of course, when you add all the retrospective trial, it's very tight here, and they are statistically significant. But if you add the prospective and retrospective trial together, it becomes statistically significant. Just because there's a much bigger weight for a retrospective trial because you have more patients. You have like 10,000 patients in the retrospective versus 300 in the prospective trial. So this variation in the number is good that the statistic towards becomes statistically significant. But if you use a prospective trial only, it really was not that much different. And again, this current data is a conclusion, has a limited capacity to identify women who have a low chance to conceive after IVF. The frequency report cut of 7 millimeter is related to a lower chance of pregnancy, but occur infrequently. So it is, and the use of this tool on cancellation freezing might not be justified based on this current meta-analysis. So it basically tells us that, yes, you have to pay attention, but this is alone should not be used to cancel as data or you do a frozen embryo transfer cycle. So, sorry for that. Okay. So since that time, we have been looking in a lot of different ways how to improve or how to increase the endometrium, because in our mind, endometrium above 7 or above 8 or 9 is better for implantation rate. And this is a list of the stuff that's been used for too long over the last 20 years or so. Some of them were successful, some were not. And I'm going to go over them just very briefly to discuss the different those studies. The prolonged use of estrogen, it's really a very interesting one that it's really published, like, you know, from 2006. And it showed very clearly that when the patient extended use of estrogen allows those patients to gain an endometrial sickness. So the endometrial depends on the estrogen and circulating estrogen. So the longer it's going to get exposed for that, the likelihood that it's going to result in sicker endometrium is increased. And again, some of this patient is a therapy between 14 to 82 days. That's a very long, okay? But definitely as a longer progression, those patients have failed in previous cycles, the endometrium was thin. In subsequent cycles, they put them in a higher dose of estrogen and put them in estrogen and follows them for a longer time. And the longer the extended estrogen exposure, the more this endometrium become thicker, right? So extended estrogen administration followed by frozen throat IVF program is beneficial for women with thin endometrium. However, the risk of abnormal placentation. One of the patients that they have a placenta previa. But the taking point here, a prolonged exposure to estrogen might be beneficial for the patient for a thin endometrium. Then came the 2000. I remember the study very well. The Share group from Las Vegas came with this idea that if you use a Viagra, Jeffrey Shea used a Viagra that would improve the patient with increase the sickness in the endometrium. And I mean, okay, so I already said Viagra is sildenafil citrate, is a phosphodiesterase 5 inhibitor. It enhances the vasodilatory effect of nitric oxide, increases endometrial blood flow. And all they had is 4 patients. This all they had. They had a 4 patient that previously had a narrow, a thin endometrium, 5 to 7 millimeter. I used Viagra 25 milligrams 4 times per day, and then the endometrium becomes sick, and even, you know, and that was the beginning of that the use of Viagra 2000. This is followed by another study with basically a bigger study that was Robert Wood Johnson in New Jersey, and looked at to see was it really adding Viagra would help or not, and basically have those patients that did not reach 8 millimeter on the oocyte retrieval cycle, and then on the subsequent cycles they put them on estrogen, one group, and the other groups they put them in estrogen and sildenafil to see the endometrial sickness. And of course, they come to the conclusion putting the patient in vaginal estrogen or estrogen and Viagra together did not affect the endometrial sickness. And with the conclusion, this data failed to corroborate the previous claim that 25 milligram intravaginally would improve endometrium. And I think that start like just basically go by sideways, and we start to forget about using a Viagra in endometrial sickness. This was one of the abstracts. This is Dr. Muhammad Aid, and he has this abstract again in 2015 SRM. And again, this did not come to publication. And the interesting part in this one, he only not look at the endometrium thickness, which is 5 millimeter. He also looked at the pulsatility index. So the pulsatility index is the blood flow in the level and uterine arteriole endometrium, and to see how the blood flow goes. If you have a higher pulsatility index, basically have a resistance of blood flow, and subsequently you assume that has a lower, it would impede the growth of the endometrium. So what he saw like 68%, 15 out of 22 patients, and it actually improved in the pulsatility, have decreased pulsatility index, which is basically mean they will increase the blood flow to the endometrium and subsequently can improve the endometrial thickness. And he reported that much improved pregnancy rate and as well as in the implantation rate. Again, those were 22 patients, and it was an abstract, never came to publication. So has been much going about using Viagra as endometrium sickness, and still the jury is still out there whether that's something can be used or not. Now the second thing that we start to talk more and more about it is a low dose aspirin, to whether it really improves endometrium or not. Again, this is this is oocyte donation cycle. So those are patients that undergoing oocyte donation, like and so they are older women. And on the previous, when they start to prepare the endometrium for implantation, for the embryo transfer, and the endometrium was thin. So this is an older woman that using a donor oocyte or donor embryos, like donor oocyte that fertilized become an embryo. And so the idea behind aspirin is again this lower pulsatility index of the uterine artery, and subsequently improves the blood flow. Again, it's working again through increasing the blood flow to the uterus, and hopefully that brings and deliver a lot of more estrogen toward the endometrium. And again, it's 15 recipient and divided into the group, and it was very interesting. There was no demonstrable increase in endometrial sickness in the aspirin treated group versus the one did not treat. So aspirin did not improve endometrial sickness. However, they saw it improve implantation rate, 24% versus 9%. And the conclusion was the low dose aspirin may improve implantation rate and oocyte donation recipient with a thin endometrium. And this is that's a finding. If you look at the endometrial sickness between the low dose aspirin and non-aspirin, 7.1, 6.83, not much difference in the endometrial sickness. But if you look at pregnancy rate, the delivery rate, and implantation rate, were higher into the aspirin group versus the endometrial group. Again, endometrium did not get any thicker, and according to this, is improved implantation rate. Then this is study who came about, again, endometrium in the patient, thin endometrium receiving intrauterine insemination. And again, this is not an IVF, but but it's a patient that used to have a thin endometrium. And the good thing about the study is one of the big studies that have big numbers of 114 patients on aspirin and 122 patients on non-aspirin. This is a significant large number of patients in a trial like we see. So the more important part of this, again, what they noticed differently in this patient, the trilaminar patterns, how the endometrium looked like between the aspirin group and no aspirin group. They did not see a change in the pulsatility index, that's or the resistant index of uterine artery. However, if you look at the two things that were statistically significant, the trilaminar pattern of the cycle, it was like 46% in aspirin group for non-aspirin. The thickness did not change. The thickness was 7.2 versus 5.8. Although it's like a little bit more, like on the aspirin group was not statistically different. And the last one is the pregnancy rate was higher in the aspirin group. So two things, did not change the thickness, but again, it's increased pregnancy rate on this group. So now we came more to the more recent stuff, like, okay, the endometrium is thin, we try Viagra, we try aspirin, we try extend estrogen for longer time. And then there came the granulocyte colony stimulating factors, the CSSF. And it basically, this is a homeopathic cross factor. And people thought, well, if the homeopathic factor we introduce at the endometrium, it might allow the endometrium to grow and become thicker or better looking endometrium. 2011 was the first time this is introduced, and they have 4 patients with endometrium between 3 and 6.5, and again used as a vaginal route, and that showed an increase in endometrium at the 7. And actually, that the idea is those patients got pregnant, one of them was a pregnancy. And that was the beginning, in a way, that used granulocyte colony stimulating factors. However, subsequent trial of this, I mean, there's did not really show any significant difference. This always conflicting result, retrospective cohort study, no statistically proven pregnancy rate. And the most recent study also, there's no different pregnancy rate or live birth rate between the two groups, although one group had a thicker endometrium. So, and I think that since 2017, there are a few studies that try to look at the granulocyte stimulating factor that did not show a difference. Sorry, excuse me. So, endometrial stem cell, again, 2011, first study looked in the patient with Asherman syndrome and refractory thin endometrium and was treated with with endometrial genetic stem cell and showed a significant increase. After that's all like a case trial showed that stem cell might work, and most probably it worked more in the patient with Asherman syndrome with a significant increase. Again, you can see between 1 to 4 to 5 millimeter. Again, this is not it's not a blockbuster going to go from 3 to 4 millimeter to 8-9 millimeter. So we become more and more, if you look at all the stuff we talk about endometrium sickness, and this is something most probably at some point going to change, which is a descriptive part of our work. we measure endometrial sickness. Till recently, we really don't have any tests to tell us whether this endometrium is working or not. The same thing, look at everything we do. We are depending on a very descriptive morphology, more than a functional part of the study. So the ERA looked on the patient with thin endometrium below 6 millimeter. And was non-receptive in 23%. 3 out of 13 was non-receptive, and 10 out of 6 was receptive. And the good things, this was the same as the patient with thicker endometrium. So the patient had less than 6 centimeter endometrium or more than 6 centimeter endometrium, the receptivity is the same on the same group. And that takes us to the point is that most probably endometrial thickness could be important and the measurement could be important, but the function of the endometrium is most probably more important than the descriptive, the trilaminar and how many millimeter would be. This is one of the, that's one our protocol we use this, and again, that's going to be scalable that allow us. So we always put on our patient aspirin, put them in H1 milligram daily aspirin. We always start this patient on an estrace 2 milligram BID between day 3 to day 5 or day 2 to 5. By day 6, we start to increase estrace to 3 times a day. And then around day 9, we're adding estradiol patches for this patient. And again, all of those allow us to be scalable. Sometimes we use 1 patches every, like 2 patches every 72 hours, or we can go up to 3 patches every 48 hours. We also use estrogen vaginal cream if this endometrium is not progressing. As we talked earlier, we use progesterone oil, and the progesterone oil we use anywhere between 50 to 100. So in a thin endometrium, we tend to go toward the 50 milligram daily versus the 100 milligram when we're starting on the endometrium development, we go on a higher dose of endometrium, a high dose of progesterone. And we start anywhere between day 12 to day 16. Once the endometrium reaches certain thickness, we start there. We use 6 days of progesterone before we do our embryo transfer. And again, this is all scalable. I mean, we don't do everything the same for everybody. Again, we look at the endometrium, again, we try to use the best tool we have to use the best time we can do the embryo transfer. This is one of the interesting, like, this is a management of thin endometrium in assisted reproduction, clinical practice guideline from the genetic fertility. And they did a very good work, really an amazing work, trying to look at all the data, try what's work and what's not gonna work. So in patients with thin endometrium undergoing embryo transfer cycle, we suggest again the use of pentoxifylline, HCG, gonadotropin hormone, platelet. So all of those stuff that we thought that may work, there's really no data to suggest or to support the use of any of those patients with endometrium. Even the patient with endometrium, there's not much data to support the use of GCSF, right? There's very weak evidence. The same thing, the same use of Viagra in those patients. The only really thing that comes with strong evidence that the patients below 7 millimeter might have a negative impact on pregnancy and live birth rate. We really don't know which protocol going to work for this patient and what's the best protocol that we can use or do. So in conclusion, thin endometrium is an infrequent but challenging finding occurring in patients undergoing ART or fetal embryo transfer. Endometrium sickness during stimulation might predict endometrial response during FET, and that's what we use. So like if during the stimulating cycle, the patient endometrium is 7 or 8, we know most probably going to have a hard time when it goes to FET. Most probably the endometrium going to be in the 6 or 7 millimeter. And those most likely the patient we're going to see them more often will be very aggressive in managing their estrogen, whether in starting the batches earlier, high dose batches, adding batches, and so on and so forth. Adjusting progesterone dose, that's really important for us. Patient with thin endometrium, we know, as Dr. Walid said, progesterone tends to make the endometrium thinner. That we know that because progesterone is in a way the anti-estrogen. So in patient with a thin endometrium, we usually use a lower dose, like 50 milligrams of progesterone versus 100 milligrams. We do ERA. I mean, the patient that I'm not comfortable with 6 millimeter, 7 millimeter, and we really cannot get them higher than that. We end by sometimes doing ERA just to be sure that we are in phase and the endometrium is receptive on those patients. It's a great tool, and I think more and more we're going to go to functional testing rather than descriptive testing that we do right now. Aspirin improve pregnancy without increasing endometrial thickness. We really believe in this. So all our patients that we're going to go transfer on them, we put them on H1 milligram aspirin, regardless how thick in the endometrium, and we don't use it for a thickness of the endometrium. And again, this is more like, again, try to go to the functional part more than the descriptive part. And again, we most probably need a large design in the randomized trial. And this is very difficult in our field. If we want to hear for the last 2 hours, how many protocols are there for frozen embryo transfer, and how many protocols out there for when you start progesterone, stops progesterone, it's going to be very hard to stratify that. And a lot of stuff we do it based on our intuitions, what we think is works in our hand, and what we feel, and going to stay that. I mean, we have to recognize it's really what this field is still in its very primitive stage. We really don't. There's a lot we don't know, and what we're trying to do here is trying to figure the best way from the tools we have, and till we start to move more to a functional testing, rather than descriptive testing and so on and so forth, I think we're going to be still like talking about this for the next 10, 15 years. But anyway, thanks so much for the time.